Hi, I'm Margaret Lehman Blake, also known as Peggy Blake. I'm an associate professor and a speech-language pathologist. I work primarily at the University of Houston and also here at the UT Health Science Center in Houston. Today we're going to be talking about communication, culture, and aging. I'd like to first acknowledge the funding source for this project, the Health Resources and Service Administration of the Department of Health and Human Services. Now, the objectives for today, we're going to talk about cultural competence and cultural awareness and how those are different. We're going to talk about communication and how it can be affected by culture and cultural backgrounds. We're going to talk a lot about speech and language and cognition, three components of communication, and how those can be altered by the normal aging process, as well as diseases that are commonly associated with aging that also can affect these communication processes. So the outline of what we're going to do today. We're going to start by delineating some components of communication, and as speech-language pathologists we have very specific categories of communication, and we'll talk about those. We're then going to talk about cultural influences on the various aspects of communication. We will then talk about aging and how that may or may not affect the normal communication processes, and then finish up with some communication disorders that are commonly associated with diseases and disorders that you see in older adults. I'm going to start by talking about components of communication. As speech-language pathologists, again, we divide communication into several different but interrelated components. So first we have speech. Speech is a motor system, and it is used to produce sounds to create words and convey meaning. So creating the different sounds that you need to string together to create a single word, that's part of a speech process, and it really is a motor task. Then we have language. Language has to do with words and finding the words that you need to express your thoughts and ideas and combining those words into grammatical sentences. All of those processes are language processes. And then there is cognition. Cognition is your thoughts and your ideas, your intellect or cognitive functions, things like memory, attention, problem solving, reasoning. All of those things are part of cognition. Now, communication involves all of those, and as I mentioned before, these things are very interrelated. You have to have the combination of the sounds that make up the words that you have selected, and those words are things that convey your thoughts and ideas. And so again, all of these are very closely interrelated, but they're also very distinct processes. So with communication, you have not only the speech, language, and cognition, but then how you use these things, how you use language to communicate. This is what we call pragmatics. And it includes things like what you say, what topics you choose based on the audience and the setting. If you talk about personal items in a public setting or only in a private setting, and with whom you share these types of things. It also includes some of what we call nonverbals, things that communicate but aren't part of the verbal language system. So this includes things like your tone of voice, how you say something. It can include body language and facial expression. So all of those things that add to your communication message and may add more than what the words say. And so all of these things together, speech, language, cognition, and then how you use those in pragmatics, all are working interrelatedly to create communication. So now we're going to talk about communication and culture and how those two things are interrelated. Culture affects how we communicate, and it can affect small things that seem rather minor, and then it can also communicate more weighty items also. It can be in terms of greetings or formality, how formal you are in greeting people, and how you greet people that you know well, who you're seeing again, or how you greet new people who you are meeting. It can affect the topics of conversation. What kind of information is shared with whom and what other groups of people? So we have topics that we share within the family, but may not be that comfortable sharing with other professionals, even medical professionals. Information that be shared only within a group of males or only within a group of females. And your cultural background helps dictate what kind of information it's okay to share with these different types of groups. It can also influence how direct you are in communication. If you're very direct and say exactly what's on your mind, you get straight to the point, or if you kind of talk around the subject or hint at it and get to it not quite in such an abrupt manner. Now, who talks to whom is also in part culturally based. In some cultures, there is a family spokesperson or decision maker, and this would be the person who, in a medical setting, would be the one to talk to the doctors and the other medical professions to get the information, and then that person would convey it to the rest of the family. In other cultures, it's the person who has the problem or the person who's seeing the doctor who would be the one with whom the doctor would communicate, and that person would be a primary decision maker. Nonverbal communication also can be impacted by different cultures. Eye contact, whether or not you make direct eye contact, and if you do, with what group of people? Do you make direct eye contact with people who are in a position of authority or not? Or is direct eye contact really limited just to personal friends and family? The use of facial expressions, body language, prosody, which is another word for tone of voice. How do you use those things to convey information? And do you use those more than the words that you're actually saying? Personal space is another aspect that can be impacted by culture. So how close do you get to somebody when you are talking with them? And does it depend on how well you know them or what your role is and their role is? Is it okay to touch somebody on the shoulder or on the arm as you're counseling them, or is that not culturally appropriate? So all of these things can be affected by someone's cultural background. It used to be that people talked about cultural competence and being competent in different cultures and understanding different cultures and how they communicate and how you should communicate in deference to that. But more recently, people have been talking about cultural awareness, so shifting the focus a little bit away from competence and more towards awareness, because it became apparent that we can never be fully knowledgeable and competent in all cultures, because there are so many different cultural backgrounds, and there's no way we can know all of the specifics of all of the different cultures. So instead, what we talk about is cultural awareness, that we need awareness of the potential differences between our own native culture and the culture of someone who we are seeing in a medical setting or in a social setting. Also, that applies. And so this includes awareness of communication differences, the way people may communicate differently, all those things that I just talked about with eye contact and body language, or what kinds of topics they would feel appropriate to talk to you about. It also includes cultural responses to aging and health and disability, end-of-life decisions. So somebody's cultural background may influence how they see aging. They may see it as a good thing where you gain wisdom, or they may see it culturally as the end of life, somebody is slowing down and not contributing to society, and their worth in the society also decreases. And that's an important item to be aware of, because their cultural background is going to influence how they feel about aging and what they're willing to do about some of the problems that are associated with aging. Now, the role of family and community is also really important. In some cultures, family is really important, and the family is involved in major decision making. In other cultures, family is less important, and it may just be the patient and his or her spouse who are involved in the decision making. And that's also important when you are working with patients or clients, to be aware and ask them what their preference is in terms of including family members in information sessions and decision making. Now, one critical point about cultural awareness is that it should include an awareness that all cultural groups are heterogeneous. So if you think about just within the American culture, we're all different and we communicate differently. Some people are very blunt and very straightforward and to the point, and others don't like to approach subjects so directly. And they may kind of hint at something or, provide a little bit of information, but they don't tackle things head on. And if you think about people that you know who all grew up in the American culture, people communicate differently. And they have different views on aging, and they have different views on family and the importance of family and all of those kinds of things. But collectively, we can talk about the American culture. And when you're dealing with people from other cultural groups, from China or from Mexico or from India or wherever your patients are from, you need to be aware that the cultural stereotypes may not apply to them. And so this awareness, again, is an idea that, yes, we have these cultural backgrounds and they may influence some of the things that the people do or the way they communicate, but they also probably are not going to fit the stereotype exactly, and you should be careful not to peg them into that stereotype. Now I'm going to present some information and some examples, and I've gotten these from the Center for International Rehabilitation Research Information and Exchange, or CIRI. It's through the University of Buffalo, and it's a really good site that provides a lot of information. They have information on I think at least 20 different cultures, and it includes things about in their view on family and society and community involvement, religious background, communication, and a lot of different types of information for each of those different cultures, and I find it really valuable. So before we go into some examples, I want to talk a little bit about acculturation. When someone is moving from one culture to a new one, we talk about their level of acculturation. And this is the extent to which a person accepts the cultural beliefs and practices of their native culture and the adopted culture. And there are 4 levels of acculturation: integration, assimilation, separation, and marginalization. With integration, an individual is able to meld their native culture with their new culture. So they find some aspects of the culture that they grew up in and they hold on to those, but they're able to mold those and meld those seamlessly with aspects of the new culture. People who are really well integrated are people who are really living what we call a bicultural life, because they're able to take aspects of the two and there isn't conflict in that. Another level is assimilation. This is when someone will discard their native culture and adopt the new one. So for example, someone coming from China who moves to the United States, who really leaves behind a lot of the ideas from their Chinese culture and adopts the culture of the United States. Then there is separation. Separation is when a person withdraws from the new culture and stays with their native culture. So sticking with our example from before, this would be someone who comes from China, comes to live in the United States, but really identifies most strongly with their native Chinese culture and doesn't accept the beliefs or the practices of the American culture. The final category is marginalization. And marginalization is when an individual doesn't really identify with either their native or the new culture. And so they're kind of in limbo. They don't really accept the old cultural ways where they came from, but they also don't feel a part of the new culture. And so the marginalization, as the name suggests, means they're kind of on the margins of each one and they don't really feel like they belong to either completely. Now these 4 levels of acculturation are going to add to the heterogeneity of the cultural groups that I mentioned before. So when you see patients, maybe one day you see 2 different patients from different families and they both came from India. Now depending on where in India and their ties to India may affect how they communicate and things like that, but also their level of acculturation. If one person is very integrated and has melded the 2 cultures, then the interaction with that person is going to be very different from someone who is in the level of separation, where they're really tied into their native culture. So again, this is just to point out the fact that people are going to be in different levels of acculturation, and so that's going to impact how they communicate and how you may need to respond to them. One other aspect of culture that I wanted to point out is what's called high context or low context communication. And these have to do with the importance that is given to the verbal message versus the physical cues and the social situation in which the message is delivered. People who are from a high context communication and from a high context culture tend to use body language and facial expression to convey a lot of information. And sometimes those physical signs are more important than the words that they're actually using to communicate. And so it has to do with the physical context that's going on and the social situation in which the communication is going on. And those are really important for interpreting what the person intends and interpreting their message. High context communication is more common in cultures that are really community or society focused, where community plays a very important role. Now, on the other end of the spectrum is low context communication. And in low context communication, the most importance is given to the verbal exchange, the words that you use and the grammatical structures that you use to convey information. So while there may be body language and facial expressions along with the message, it's really what they say that's more important. And the other nonverbals may provide a little information, but they don't carry the key to the message. Low context communication is more commonly seen in individuals who come from individualistic societies, where the individual is more important than the community at large. So I wanted to give you some examples. These examples are all from that CIRI website. And just to point out some differences, and again, these are generalizations about different cultural backgrounds, and so just be careful in generalizing these to every person that you see from these different cultures. Now, I've picked specifically China and Mexico and then India because we have large numbers of people from those cultures here in the Houston area. Okay, so in the United States, in general, we communicate very directly, where people will get straight to the point and say exactly what they mean, and there's not a lot of kind of beating around the bush, but people communicate rather directly. Now, this can be interpreted by people from other cultures as us being pushy or rude or brash, okay, where we come straight to the point. In America, that's a typical way to communicate, but other cultures may see it differently. Another thing about communication in the United States is that we use direct eye contact very commonly, and making direct eye contact with someone signals that we're paying attention to them, and that's a sign of respect to keep eye contact with someone who's talking. Now, I'm going to contrast this to generalizations about communication in the Chinese and Mexican cultures. So in China, one of the things that they do in communication is they want to avoid offending people or creating embarrassment. And so oftentimes they won't come out and communicate directly, but kind of talk around a subject or hint and see if that person is willing to talk before they address it. And this may be interpreted by others as people from China being very wishy-washy. They can't get to the point. They talk around things. But they do that in order to meet this other cultural goal, which is to avoid offending people. Also in the Chinese culture, eye contact with the superior or elder is considered to be threatening or considered to be an act of disobedience. So when people from China are addressing people in the medical profession, perhaps a doctor who they see as having authority in that particular situation, they may not make direct eye contact because to them that would be rude and disrespectful. And so we, coming from another culture where direct eye contact is a sign of respect and a sign of attention, we need to be aware of that and not misinterpret that they're not listening to us or they are disrespecting us. Now, another aspect of cultural communication I wanted to point out is both in the Chinese and Mexican culture, respect for adults is very important. And adults should be addressed as Mr. or Mrs. unless they ask you to call them by their first name. And that should be your inclination on the first time you meet somebody, and then you need to be invited to use their first name if that person would like you to do that. So now I wanted to talk about cultural influences on the role of family. In the United States, generally, when children become adults, then they leave their parents and they go off and they make their own home and they live independently of their parents. And generally, if they are living with extended family, it's usually an unusual situation, and they are doing that out of necessity, either health reasons or financial reasons. But for the most part, the extended family is not as important in the American culture as in others. Now in China, the traditional beliefs include the idea that family is very important, and multi-generational households are very common, where people will live with their parents and grandparents. And there's a pervasive idea that it's important to sacrifice the individual for the family in cases where that's needed. However, in the past 50 years, there have been many changes in China, many cultural shifts. And at this point, there's really no standard family setting. And so some people will maintain that multi-generational setting, but others will be more individual, where the children will move off and it will look a little bit more like the American family stereotype. In Mexico, family also is very important, and in general, children take care of their aging parents. Also, in many families in Mexico, the male is seen as the provider and is responsible for the household. So he would be the one in charge, would be the primary decision maker, would need to be involved in informational meetings about health issues, and would be the primary decision maker. However, in most cases, the mother's approval is also important. So a decision may not be made unless the mother approves of it, even if the husband is the head of the household. Now in India, family also is very important, and extended families often live together. And this may be parents and grandparents, also cousins or aunts and uncles also may live in one setting. Now in terms of cultural influences on communication with healthcare providers, so I just have two examples here. In the Mexican culture, respect is very important, but it goes in both directions. And so they will have respect of your credentials, your positions as a healthcare provider, but they also expect that you will show respect to them in turn in their position as the patient. In India, many people will also have respect for medical professionals, respect for our credentials and our education. And patients often will take on a passive role and take all the information that we provide to them. However, in many cases, if the medical recommendations contradict their cultural or religious beliefs, then the recommendations may be ignored. So they may not question you in your office or in the setting where you're providing the information and the recommendations. They may be in that passive role and take all the information, but then later decide that they're not going to follow through with that. So I wanted to shift just a slight bit here and talk about cultural views on aging and disability. So generally, people's views on aging depend on two major factors. The biological changes, these are physical and cognitive changes that occur with the aging process, and also the socio-emotional and social status changes that may occur, and these are more culturally biased, whereas the biological changes, everybody is going to have degeneration of their body and a slight degeneration of their brain as they get older, just because that's the way the human body works. But the socio-emotional and social status changes are more linked to cultural beliefs. So two broad influences that impact people's views on aging include the socioeconomic and belief structure. So in some cultures, the focus is put on the socioeconomic status, where older adults retire and they leave the workforce and they're seen as less able to contribute to society at large. And cultures that have this view will have a more negative view of aging because these adults are not contributing as much as other people. The other influence is the belief structure of the culture. So cultures that put a prime importance on family, who have strong models for a head of household, and who may participate in ancestor worship, these cultures tend to look at aging as a more positive process and a more positive aspect of life because people are gaining wisdom and they are retaining social status within the family, if not in the society at large. So I want to talk a little about this study conducted by Lockenhoff and her colleagues. And what they did in this study is they surveyed college-age students on their perceptions of aging and what they felt their societal views on aging were. And they surveyed individuals from 26 different cultures that spanned 6 different continents. And what they found is that in the vast majority, in 21 out of the 26 countries, aging was viewed rather negatively. And the most negative views were in the countries of Serbia, the Czech Republic, Argentina, and the UK. Now, the 5 societies in which aging was viewed as either a positive aspect of life or it was more neutral, those countries included mainland China, India, Malaysia, New Zealand, and Russia. So mainland China and India, as we discussed before, have a strong belief in family, and that may have influenced the view on aging. Now, another aspect of this study was they asked people what characteristics do they think decrease with age and what characteristics or aspects of a person increase with age. And what they found is that those that were consistently rated to decrease with age were related to the biological and cognitive processes. So attractiveness, the ability to learn new things, and the ability to do everyday tasks and activities, those are all related to the biological processes. Now, the characteristics that were generally perceived to increase with age had to do with wisdom, the respect people received, their knowledge, and their authority within the family setting. Now, the one item that was perceived to not change really with age was life satisfaction. So these college-age students didn't see that as people got older, their satisfaction with life necessarily decreased. So now that we've reviewed some of the ways that culture can affect communication, now we're going to segue into communication and aging and what changes you might be able to expect in someone who is getting older. So in general, the changes in communication that occur with the normal aging process should be pretty minimal. There are some changes related to motor or sensory declines. For example, if someone has a hearing loss or a vision loss, that's going to affect how well they communicate. But the changes really should be pretty minimal. If there are larger changes, then this may be a signal that there's some pathological process going on, some degenerative disease or something else going on that's really affecting how someone can communicate. In general, the functional ability to communicate, that is your ability to communicate the things that you want to, your wants, your needs, your ideas, all of those things, your ability to communicate those on a daily basis should not change as you get older. Now we're going to break it down and talk about the areas of communication that I introduced initially, speech, language, and cognition. So with speech, again, there should be minimal changes. Oftentimes, as people get older, their voice becomes weaker. They may have kind of a gravelly vocal quality. And this is due to the reduced muscle tone in the larynx. So the muscles of the vocal folds that are housed in your larynx, those muscles deteriorate and degenerate over time, just like all of the other muscles in your body. And that contributes to this weaker, gravelly vocal quality. Articulation, or the ability to produce speech sounds, can be affected, but usually it's by more peripheral factors. So if someone has lost some teeth, that may impact how they produce some certain sounds. If they have dentures that don't fit very well and they may move around while the person is talking, that may affect their ability to articulate or speak clearly. In terms of language, again, there shouldn't be any changes in functional language use, the ability to express wants and needs and thoughts and ideas. Now this graph here shows along the bottom you have the ages from age 70 to 82, and the 2 lines on the graph, the red line represents the number of ideas conveyed per the number of words, and then the blue line represents grammatical complexity, so how long and complex the sentences are. So you can see that in the mid-70s, someone's grammatical complexity generally declines. So you can see that change in there. And so people are speaking with shorter and simpler sentences. However, when you compare that with the red line again is the content, how many ideas you express for the same number of words. And you can see that that remains really quite consistent, maybe a slight drop here or there, but in general, the ideas conveyed remain consistent even though the grammatical complexity does decrease. Another aspect of language is word finding problems. Now these are the issues that we all have now and then, where you're talking and all of a sudden you can't think of the word that you want. These problems do become a little more pervasive, usually after age 70, and people will notice that more often they can't find the word that they need. There was a study that was conducted that looked at discourse or story production. And what they did is they asked older adults and younger adults to tell stories. And what they found is that older adults tended to produce stories that were more tangential, meaning they went off on tangents, so they'd start a story, but then they'd add something that kind of took away from the main point. The stories were less efficient, in part because of these tangents. And they were also more egocentric. So the stories more often were about that person than other topics in general. However, when they asked the people who were rating these stories, which stories are more interesting, those of the older adults that happen to be more tangential and egocentric, or those of the younger adults that were more consistent and to the point, people found that the stories from the older adults were a lot more interesting. So even though they're becoming slightly less efficient and more tangential, they're more fun to listen to. All right, so moving on to cognition. There are changes in cognitive or thinking processes that occur as we get older, but it really depends on exactly what you're talking about. So there are declines in what are called process tasks, or what some people refer to as fluid intelligence. And fluid intelligence includes things like memory, reasoning, learning new things, tasks that for which processing time is really important, where you need a fast response, or tasks in which inhibition control is important. So that would be not responding to a certain stimulus, kind of like not saying the first thing that pops into your head. That's good inhibition. Now, tasks or activities that require these type of processes, there is a decline that starts as early as age 20, and it's a pretty linear decline. However, when you look at other tasks, what some people call product tasks, or other people refer to as crystallized intelligence. These are things like vocabulary, comprehension, the knowledge that you have learned throughout your life. These generally stay relatively stable with only small declines, and those begin around age 50. This graph shows the difference between the declines in the process and the product tasks. And the graph is based on many, many years of work by Timothy Salthouse, who has been studying aging for decades. And if you look at this graph here, so you can see along the bottom, those numbers represent ages from age 10 up to age 80. The red line represents the process tasks. So those things requiring memory, reasoning, fast response times, things like that. So you can see that during the years where people are getting educated, it's increasing, but then after that, after about age 20, then you do have a decline in those. In contrast, the product tasks shown in the blue, so you can see the gathering of knowledge and information in the formative school years, but then after age 20, it really remains pretty constant. And again, there are some declines starting around age 50, but they're really not that big. Now, I also wanted to mention, when we talk about cognition, there is a lot of variability in cognitive ability, and this is present across the ages. And so a group of people in their 20s would have a lot of variability in terms of their cognitive abilities, as well as people in their 70s or 80s. So Salthouse estimates that at most 36% of variability in any cognitive task is due to age, and all the rest of it is due to other extraneous factors, maybe due to education or the way people think or the way they learn. And in some cases, he estimates that what you can attribute to age only accounts for about 4% of the variability. So just because you're getting old doesn't mean that these cognitive changes will occur to you, and you shouldn't assume that a patient that you see who's in her 80s is going to have a lot of difficulty with cognitive processing. Another interesting aspect of the aging research is that our definition of old changes. So 10, 15 years ago, people who were considered old were 65, maybe 70. Now in the aging literature, people who are considered in the older adult group, that age range has increased, and sometimes it doesn't start until 70 or 75. And Salthouse noted, kind of tongue-in-cheek, that what he's found is that any researcher's definition of old tends to be about 10 years older than the researcher is at that time. All right, so now we're going to shift to communication disorders. So these are going to be disorders of speech, language, or cognition that are related to a pathological process. Okay, so these are things that you would not expect to see in someone who is a normal, healthy, aging adult, but would indicate that there's some other process related to aging, like stroke or dementia, that is impacting communication. We'll start again with speech and talk about speech disorders. The main group of disorders of speech that you see in the adult population is referred to as dysarthria. And these are disorders of speech production, acquired disorders. So these are things that are a result of some pathological process. And they can be caused by weakness of the structures that you use to produce speech, the lips and the tongue, maybe the vocal folds also. It could be incoordination of these structures, as they must work together to produce any speech sounds. It can be a change in the muscle tone, either reduced muscle tone or flaccidity of the muscles, or increased muscle tone that we see in spasticity. It can be a result of controlling the movement of any of those articulators. And in speech pathology, we have a lot of different types of dysarthria that we diagnosed based on the types of impairments, whether it's weakness or incoordination or a change in muscle tone. And these impairments that we see are directly linked to the location of damage. So the damage may be in the cortex, it may be in motor structures such as the basal ganglia or the cerebellum, or it could be in the neurons and the nerves that take the muscle signals out to the muscles themselves. Another type of speech disorder is called apraxia of speech. Now, because speech is a motor process, and you need to coordinate and send signals out to all of those different structures that I mentioned before. So for example, the lips and the tongue and the vocal folds. So in order to say a simple word like pop, you have to coordinate what the vocal folds are doing, what the lips are doing, and what the tongue is doing, and what they're doing in sequence as you produce the P and the ah and the P sound in order. So in the brain, there is an area that helps control this and create a motor plan and coordinates the signals that need to be sent down. When this area is impaired or damaged, then someone may have what's called apraxia of speech. Diseases or disorders that can cause dysarthrias include anything that affects the motor system. So Parkinson's and Huntington's disease that affect the basal ganglia can result in a dysarthria. Amyotrophic lateral sclerosis, or ALS, can cause dysarthria, and most of the time it does at some point in the disease process. Damage to the cerebellum, or a stroke that affects anywhere in the motor system. So it could be the motor cortex, the neurons taking the signals from the cortex down to the muscles, the basal ganglia. Any of those areas, when they are damaged, have the potential to cause a dysarthria. Now, disorders of language. The most common acquired disorder of language that you'll see in adults is called aphasia. So again, it's an acquired language impairment, and it's a disorder of the language system. It's not caused by cognitive disorders or motor or sensory impairments. These may co-occur depending on the damage that caused the aphasia in the first place, but they are not the primary cause of the language disorder itself. Aphasia affects all modalities. That means auditory, visual, gestural, and oral. So it will affect how someone expresses themselves, either verbally or through writing, and also their ability to comprehend language. And that includes reading as well as understanding auditory input, or what they hear. In speech-language pathology, we also have a variety of types of aphasia based on the patterns of deficits. So some people may comprehend or understand really quite well, but have a lot of difficulty finding the words they want and being able to put those words into grammatical sentences. Other people will have more difficulty with the comprehension, which then will affect how well they can express themselves. Now, diseases or disorders that may cause aphasia really include any disorder or disease that damages the left side of the brain. So most commonly we see aphasia as a result of a stroke on the left side of the brain. People with traumatic brain injury, where the injury is focused specifically in the left hemisphere, also may display aphasia. Now, disorders of cognition. We don't have a good name for cognitive disorders that impact communication like we do for dysarthria and aphasia. And so generally we call it something like cognitive communication disorders, or cognitive disorders that impact communication, or something like that. You'll see many variations. Generally, cognitive disorders can cause an impairment or inefficiency in one or more of these areas: in attention, in memory, executive functions. And executive function is a term that refers to higher level cognitive processes: reasoning, judgment, problem solving, those types of things. Now, impairments in any one or more of these areas, attention, memory, or executive function, then can cause problems with language and pragmatics. If you're unable to attend well to a conversation, then you may miss some of the information, and that's going to impact your comprehension. If you have difficulty with memory, remembering what somebody said or remembering what you had told them before, that's going to impact how you communicate with them. Now, diseases or disorders associated with cognitive deficits include traumatic brain injuries, or TBIs, any disorder that damages the right side of the brain. Most often we see this in stroke, and the dementias. I'm going to talk about each of these disorder areas individually because there are certain aspects of each that are different from the others. So with traumatic brain injuries, most often TBIs occur in young adults. However, older adults who fall maybe as a result of a hip fracture or slip on the stairs, or maybe they were cleaning out the gutters and they lost their balance on the ladder, any of those things can result in a traumatic brain injury. So the common deficits that we see after TBI include problems with attention, memory, and executive function. So with attention, oftentimes they'll have difficulty sustaining their attention or being able to concentrate over time, or being able to concentrate when there are distractors going on, when the TV is in the background, or someone turns on the radio, or maybe a bird flies by the window or something like that. That will distract them from what they were doing, and it may be difficult to refocus their attention back on the conversation or the task at hand. A second area is memory. Short-term memory often is impaired, where it's difficult for them to hold on to information for a short amount of time in order to really understand it or get it encoded into long-term memory. Prospective memory is remembering to do something in the future. So remembering to take your vitamins or your medications at lunchtime, or remembering that you have a doctor's appointment later in the day. Those are prospective memory activities, and that is frequently affected by traumatic brain injury. And then again, executive function. Planning, reasoning, judgment, problem solving. Any or all of those areas can be affected after traumatic brain injury. In terms of language and communication, someone with a TBI may have a conversation that seems very disjointed or repetitive, and this can be linked to the memory problems or attention. They don't remember what they've said, so they repeat it, or they think that they've already told you part of it, and so then they don't add that in, and it becomes disjointed. They may have problems following conversations, especially if there's two or more people that they're talking with. Understanding conversations is actually a pretty complex task, being able to remember what the theme is, what you're talking about, and who said what, and how those different ideas are linked together. And that can be really difficult for someone with attentional and memory problems. In the same way, they may have difficulty following TV programs, even a show that they really liked before and loved to watch. It may be hard now if there are two different storylines going on, being able to follow one and then hold on to what's going on that storyline when the program shifts to a second one. Some people with traumatic brain injury may have difficulty completing multiple step directions when there are a certain number of things they need to do in the correct order. Now, right brain strokes that affect the right hemisphere or side of the brain, can cause any of those cognitive problems related to TBI, problems with attention or memory or executive function. There are a couple other deficits that seem to be really pretty specific to damage to the right side of the brain. They may have comprehension problems which appear not with just sentences, but in conversation or stories. And one key to this is they seem to have difficulty interpreting what someone means as opposed to what they say. So they misinterpret someone's intent. And if you remember, going way back to the beginning when we talked about the nonverbals that we use to communicate and the pragmatic aspects of communication, a lot of times if you think about your conversations or pay attention to the conversations you have during the rest of the day, a lot of the time what we mean isn't exactly what we say. And we use our tone of voice or we use our facial expression to kind of hint to somebody that we're telling a joke or something like that. And we convey through body language. Or the more you know somebody, you may have some phrases that you use to communicate something to someone you know well that nobody else would really understand, and they may misinterpret because they don't know the background context. And this seems to be a key problem in people with right brain strokes who have difficulty with comprehension. Another problem that seems to be pretty specific to right brain damage is what we call aprosodia. And this is a problem with the prosody of speech, prosody or tone of voice. And people with aprosodia may have difficulty either recognizing or producing prosody or intonation that's used to convey their message. So in some cases, they may not be able to express their anger or express that they're happy through their tone of voice, and it's hard to get a sense of their emotional state. In other cases, they may not be able to recognize that in somebody else. So even if you're communicating with someone and you're using a lot of vocal expression and facial expression, they may not be able to pick up on that to really understand the emotional intent. Now, two other problems, again, that are pretty specific to damage to the right side of the brain are neglect and anosognosia. Neglect is caused, we'll talk about it in the visual domain, although it can affect other sensory modalities. The visual modality is most often affected. What happens with neglect is that the part of the brain that's damaged is part of the brain that was supposed to pay attention to visual information, generally on the left side of space when the damage is over on the right side of the brain. So these individuals will have difficulty reading because when they open a book, they may completely ignore the page on the left side, or they may not pay attention to all of the text on the one page. So on a newspaper, they may miss the column that's on the leftmost side. They may seem to ignore people who are on the left side of the room or forget that they are there. And it's not that they're consciously ignoring it, but the part of the brain that's supposed to pay attention to the things over on the left side is not functioning properly. So their brain essentially isn't telling them that someone is there. Individuals with neglect may seem to lose things, say on their tray table if they're in the hospital, or if there's a side table over on the left side, they may lose things over there. They may complain that they don't get coffee in the morning when it's placed to the left side of their tray. Now, another characteristic disorder associated with right brain injury is what's called anosognosia, and this is a reduced awareness of deficits. Now, it commonly co-occurs with neglect, but it also can co-occur with any of the other deficits that we've talked about. So someone with anosognosia won't really be aware that they have deficits. Or they may be able to say, yeah, people have told me I have trouble with that, but they don't really accept it for themselves. Again, their brain isn't telling them that something is wrong. And if your brain doesn't tell you something's wrong, then it's hard to really believe other people when they tell you that it's really there. So the last area that I want to talk about briefly is the dementias. So with the dementias, you have patterns of communication impairment that vary depending on the type of dementia. And I'm just going to talk about two of them here that have some pretty characteristic language and communication deficits. So we'll talk about Alzheimer's and then the frontotemporal dementias. With Alzheimer's disease, we know about the memory problems that are linked to Alzheimer's, and I'll go through those in just a minute. But I wanted to talk about the language problems. People with Alzheimer's lose their ability to form ideas. So remember, in communication, you have the cognitive aspect where that's where your thoughts and ideas come from, and then you need to find words to express those, and then program the speech system to produce them. In Alzheimer's disease, their ability to form ideas is affected. Now, their structural language initially remains fine, and then in the very late stages of the disease, these may be affected too. But initially, the word form, how they create the words, their grammar, all the sounds they use for the words are all intact. Their automatic speech is also intact. So if you come in the room and say, good morning, they might say, hi, how are you? And the automatic responses, those are preserved until fairly late in the disorder. However, they do have a decline in the semantic system or the meaning system. And this contributes to the decline in the content that they express. So they may have difficulty finding words that we talked about in normal aging, but when it gets beyond a certain point, we diagnose it as anomia, which is a deficit in word finding. So they may not be able to find the words they want on a pretty consistent basis. And it's not like what we usually experience where, usually the words that you can't find are a little bit less frequent words or one that has a very specific meaning that you need for a specific context. Someone who has anomia will have difficulty finding really pretty common words like pencil or dog or table. Over time, someone with Alzheimer's, their vocabulary will shrink over time. So out of all the words that they used to be able to use to communicate at one point, they have fewer of those words to choose from. So some of the decline in the content or what they convey is linked to the fact that they have fewer words to choose from, and that limits what they can convey. You also will notice that they increasingly use vague words, things that don't really convey a lot of information. Oh, that thing over there. And phrases like that convey a little bit, but really not very much. Now, these language deficits you will see in addition to the cognitive deficits, the deficits in short-term memory that cause difficulty with new learning. They may have attentional problems, especially when there are distractors. So they may have a lot of difficulty when a TV is on in the background because it's hard to ignore that noise in order to pay attention to the conversation that's going on. They may have kind of a generalized slowing. So their response time, their movement time, their decision time is slower than you would expect for someone of that age. And also some executive function deficits may occur. Problems with initiation, starting a response, starting a conversation, or planning a conversation, planning what you want to say to somebody. All of those things can be affected in Alzheimer's and obviously will affect how well they communicate. Now finally, I wanted to mention the frontotemporal dementias. Some of these used to be referred to as Pick's disease, although I think frontotemporal is the preferred term now. Deficits that you see in patients with these type of dementias have to do with the location of the damage, the degeneration of the frontal lobes of the brain and the temporal lobes. Oftentimes they will have attentional disorders, so they'll be very distractible, have difficulty ignoring the noises or the distractors in the background in order to pay attention to a conversation. They may start to exhibit socially inappropriate behaviors. Some of their behaviors will be very stereotyped and ritualistic or repetitive. They'll do the same things over and over. Some people become hyperoral, and they'll put things, non-food items, in their mouth. Some of them also develop hypersexual behaviors. Some will develop personality changes and mood changes. They may show an emotional disconnect. They're not really emotionally linked to a situation. Some of them will develop depression or anxiety. In terms of their language output, what they convey is reduced over time. And oftentimes they'll develop a stereotyped phrase or sentence, and they'll use that repetitively. Now, in general, their comprehension is going to be preserved until late in the disorder, because comprehension is not controlled by the frontal lobes or the anterior part of the temporal lobes. So they'll be able to understand what's communicated to them, but will have difficulty then expressing themselves. So I want to leave you with some hints for communicating with older adults. And these are primarily for adults with communication disorders, but you can use them for any older adult that you believe is having some slowness of processing. So there is a type of speech called elder speak, and this is a simplified form of speech or expressive language that's used with older adults, in which the grammar is simplified so the sentences are a little shorter and a little simpler, and the rate is slowed. Now, the benefits of using this type of elder speak are that you're making it easier for the other person to understand, easier for them to comprehend, because the grammar is simpler and it's a little bit slower. And with the slowness, then it helps when they have memory or processing deficits, where it just takes them a little bit longer to comprehend. However, you have to be careful with this, because if it becomes too simplified or you slow down too much, then it sounds too much like baby talk. With an exaggerated prosody, the rate is too slow, and then this can be interpreted as being demeaning, that you are assuming that they're not very bright just because they're old, and that will impact their conversational exchange. So some suggestions on what to do, again, with adults with cognitive or communication deficits, and you can tailor these to the level that you need for an older adult. So some of the do's. If you're not quite sure you understand something, then ask them, or you restate it. Oh, did you say that you went to lunch with Mary yesterday? And restate it to confirm that what you heard was actually what they meant. When you're talking, do simplify and slow down a little bit. Reduce the amount of information that you give at one time. But these three things, you do need to do it only as appropriate for that person's abilities. You don't want to, again, assume that their brain is working too slowly when it's not, because again, that will be interpreted as disrespectful or demeaning. Do pay attention to nonverbal communication, especially for people with aphasia or speech disorders who have difficulty finding the words or pronouncing the words. They may communicate a lot through facial expression and gesture and body language, and you can use that to help figure out the message they're trying to convey. Do use nonverbal communication yourself to enhance your message. If someone has an aphasia where they're having difficulty understanding the language, they may pick up your emotion or your intent through the nonverbals. You may act as a translator, but only when really necessary, and you know exactly what the person is trying to convey. Now, if someone makes an error, they mispronounce a word or something like that, just ignore it unless it affects the meaning and you need to clarify what they actually meant to express. But if you know what they meant to say, then don't bother correcting it. A couple things that are on my don'ts list. One of the things that we do as a culture, and I think it's actually just a human condition and not specific to the American culture, is that we often assume that the way the person talks reflects exactly how their brain works. And so if someone speaks a little bit slowly or they misarticulate, mispronounce some words, then we assume that they're not very bright. And this is a big problem. With people with aphasia, their intellect is not affected. With people with speech disorders, their intellect is not affected in most cases. And the way they speak is limited by the motor system, but not by their brain. And so you need to be very careful and talk with them enough to get a sense of where their level of thinking is, so that you're not talking down to them, because that's what you perceive from their speech. Another don't assume that all older adults have hearing loss. Some do, and when you go in and you first start talking, you need to watch their responses, watch their nonverbals. If they lean towards you, then you might need to raise your voice. But don't go into someone's room just because they're 80 years old and start talking really loud, because you assume that they're not hearing very well. Another don't try to finish someone's sentence. If you know that person well and that's part of what you do, that's perfectly fine. But if you're working with someone or introduced to someone who may have a speech or language deficit, don't try to finish their sentence, because you may be wrong, and then you're going to contribute to and exacerbate the communication breakdown, because now not only do they have their message that wasn't conveyed correctly, but now they have to fix what you tried to fix that was incorrect. And the final one is don't speak for someone else unless they ask you to. So even if you know what they want to say, you need to give them the autonomy and the respect to communicate the way they want to communicate. And then if they do ask you to, then by all means step in. Here are the references, and it includes the website for the series site, again with lots of information about cultural backgrounds and cultural impact on health, healthcare, and communication. Thank you very much.